recapture. I think we can get started. So I'm sure some people will be logging on here as we get going, but just want to welcome you and thank you for giving up part of your Friday evening to spend time with us. I'm Molly Hale and I work at Riverstone Health and help coordinate our AIDS Education Training Center activities in Montana. And so I can't even think of how many number of years we've been doing this HIV update, but we appreciate getting to do this each year with the Infectious Disease Network and are looking forward to spending this next couple hours with you. If you didn't have a chance to register yet, because since we're doing this virtually, I don't have like the paperwork specifically to send to you, but I do have a link if you could register, and then we'll follow up with an evaluation after this presentation. It's just part of our funding. So I'd like to introduce Dr. Brian Wood with the University of Washington, and I'll turn it over to him.
Thanks, Molly. Thanks everyone for having me back. Bummed I can't be there in person. This pre-pandemic was my favorite AETC meeting of the year. Don't tell anyone, don't tell the other states, because I got to see you all and usually go for an adventure. So hopefully next year. Perhaps what we could do, since this is a smaller group, is just do a real quick round the horn, name and role, make sure I know everyone and make sure you know each other. So again, I'm Brian, I'm an infectious disease and HIV provider at University of Washington and Harborview, and some of you through our ECHO network, which is great. Also see some names of folks I look forward to meeting and get to know during this hour. If you're in a place where you could turn your video on, that's great. So we have a little interaction, get to know each other a little better. If you're in a place where that doesn't feel appropriate, then understand. But if you wouldn't mind doing a super quick intro, maybe I'll go the way everyone's located on my screen. Mary Ellen, would you mind?
Sure, I'm Mary Ellen Helmer, and I'm the nurse for the Ryan White Program at Partnership Health Center in Missoula. So I work with Winslow Lewis and Kate Krebsbach and Amy Matheny here.
Thanks, Mary Ellen. Jeff?
Hi, I'm Jeff Jaden, infectious disease. I'm up in Kalispell, Montana. We were formerly called Kalispell Regional Medical Center, and now we're Logan Health.
That's the Logan, got it. Thanks, Jeff. Hillary?
I'm Hillary Hansen. I'm with the Montana Public Health Institute, and I'm the coordinator of the Infectious Disease Physician Network.
Sorry, Chris?
Am I supposed to go?
Yeah, go for it.
Chris Caruso, I'm a PA at Riverstone Health. Work with Stacy Lee.
Thanks, Chris.
The Ryan White Program.
Cool. Stacy?
I'm Stacy Lee. I'm an infectious diseases provider. I'm the medical director, Ryan White, at Riverstone here in Billings.
Jeff Jansen.
Hey, I'm Jeff Jansen. I'm the infectious disease pharmacist at St. Vincent's here in Billings.
Cool. Thanks, Jeff. Michael?
Hi, I'm Michael Stevens. I'm one of the infectious disease physicians in Billings Clinic in Billings, Montana.
Cool. Thanks, Michael, for joining us. Will?
Will Gavin. I'm a nurse with the Gallatin City County Health Department working with the Ryan White Program.
Fantastic. Thank you, Will. So again, this can be formal or informal. I'll pull some slides and just show you what I was planning to talk about. I was not going to talk about COVID related things. It feels weird not to talk about that these days, but it's also kind of nice to get a breather from that since we're also inundated with info. But this does not need to be me just talking about you all. If you have questions you want to pose to your colleagues about how folks are getting anything done or doing anything across Montana related to HIV, COVID related things for people with HIV, we certainly can take time for that. I'll show you what I plan to cover, but then would like to take a minute and see what else is on your minds. I'm gonna make this so I can see you and my slides. So I don't have any disclosures or financial conflicts of interest. The only notice I'm going to give you is my dog is pawing at my leg. And if you hear him bark, I apologize. He didn't get out enough yet today. So there were a number of HIV related guidelines updates. The last year I was trying to think about what came out, what was new. It was non-COVID. So the Department of Health and Human Services adult and adolescent treatment guidelines were updated in June. I was going to go through some of the key updates there and what led to the updates, some of the places where I think we have clear data and guidance, and some of the places where I think there's still a lot of controversy and question. And then the CDC made their draft PrEP guidelines available for about 10 days. We snagged them, reviewed them, found them very interesting. I have some summaries, have some questions, but they have not been finalized. I doubt they will change much, but they have not been fully finalized. So I was going to show you some highlights from those. Things I was not necessarily going to cover, but wanted you to be aware of. There have been some important updates to the Hep C guidelines, really with the goal of simplifying things, simplifying treatment options, simplifying monitoring, especially the lab monitoring, particularly for patients who have not previously been treated and have compensated cirrhosis or no cirrhosis. So if you are a Hep C treater, those are worth looking at. The OI guidelines were updated. The most important update to that, which for those of you who are on our ECHO network heard about, was the update to the Cryptococcus section. I was not necessarily going to cover that, but it's of interest, we can talk about it. And then CDC released their new STI guidelines. I think that was a big deal. I was not going to go into that today because there have been a lot of webinars through our group and others reviewing those. But if there's questions or anything that feels unclear about that you want to pose to your colleagues here, we certainly can. So I will mostly focus on adult HIV treatment and PrEP, but let me just give a pause and a chance. What else is pressing on your mind for your patients with HIV or at risk for HIV? What's not here? Or what do you really want to make sure we cover? Just give everybody a chance.
This is Jeff. I was just checking to see if some of your treatment includes the cabotegravir ripivirine. I haven't used that, but I'd be interested in any information.
I've got a section on that, Jeff, because I both would like to share some new information and I'd like to ask you all if you're using it, because frankly, we have very few people on it, very few. And I will talk a little bit about why I think that is and would love your perspective as well. So definitely. Thanks, Jeff.
I had the very same question, actually. We are about to possibly move forward with 2 or 3 people, but we haven't done it yet. So wanted to chat about that.
Yeah, okay, let's do that for sure. So I have that. Let's do a brief update on initial therapy and then talk a bit about 2-drug therapy, and I've got a section on that. And I was going to go into the weight gain controversy a little bit. Some of you have heard me talk about that. If it's of interest, happy to talk about it. If it's not, we can skip it. It's so controversial and so also murky. But maybe I'll just dive in, but please know you can stop me at any time. And if there's things I'm not covering, jump in. Maybe this will trigger other thoughts or recollections of patients you've seen in clinic. And I think we're slotted for 2 hours. We can just see how it goes. And I know everyone's had a busy week, busy day. So if we go 2 hours, great. If we don't go 2 hours, also great. So we'll just see. But again, please feel free to dive in. I also will do my best to keep an eye on the chat box, but if you write something in the chat and I don't respond or I don't see it, please just unmute and alert me. So focusing first on adult and adolescent HIV treatment, I'm not going to cover peds HIV treatment. I'm not a pediatrician or a pediatric HIV treater, so I'm really going to focus on adult and adolescents and make a few mentions of treating pregnant people with HIV. The pediatric guidelines, I noticed, did have some updates over the last year. So if you are a treater of kiddos, please see that update. But let me just start with this, not a trick question, would just love to get your opinion. Let's start with initial therapy. Someone's never been on ART before. What do you think is the best option? Again, not trying to trick anybody, just would like your opinion of the options listed in the HHS guidelines. What do you think is the best? Let's say insurance isn't a barrier. Person says, I'll take whatever you recommend. What do you think would be optimal? Yeah, thanks everyone. So, big FTC TAF, which is Biktarvy, dolutegravir FTC TAF, or dolutegravir FTC TDF, actually beating out the TAF option. I am curious to ask you and just hear your opinion. I don't think there's a right answer here, and I just would love to hear any argument. Anyone willing to share why you voted for what you voted? And in particular, I'm curious the TAF versus TDF discussion. And it's such a small group. I can't ask, I'd rather not, but I can. And if no one volunteers, perhaps I will, but.
Okay, I'll go.
Thanks, Stacy.
I like all three of those options, actually. I don't know. I think they're all great. They're all pretty good. I kind of lean away from Triamec these days. But I chose Biktarvy. I chose Biktarvy because it's the one pill once a day. I find that the patients tolerate it best, and it just feels less overwhelming to them to have one pill once a day if it's initial ART and they've just been diagnosed. I just have had better luck getting it going without side effects. Although, Truvada or Descovy dolutegravir is also super well tolerated, maybe a little more insomnia issues with the dolutegravir, but I like all of those options, actually. As far as the TAF versus TDF thing, if I had to choose between the two, if I were going with the dolutegravir regimen, I'd probably choose Descovy. But, we have a lot of women of childbearing age, that we sometimes do put on the Truvada dolutegravir option. And then I don't know if Chris wants to speak up, but we have had a rash of fatty liver disease and metabolic syndrome. And so, yeah, if you wanted to talk at any point about this weight gain controversy, we're just really seeing a lot of it in certain populations. And so I think in some ways we start people on Biktarvy, but then we have to sometimes backpedal quickly and get them, within like 6 months to a year, we're putting them onto a Truvada something else regimen, sometimes Doravirine or something like that. So I don't know. Those are just my initial first thoughts.
Great first thoughts, Stacey. Really appreciate it. A lot in there in those thoughts, and we will come back to some of those issues. And I'm happy to give some thoughts on the weight gain issue. Chris, what would you add?
Yeah, I agree with Stacey there. I think if there's any question with people with, I think of a new diagnosis and they're, I guess, squirreliness with taking pills and adherence, I go with Biktarvy. But if it's someone that's super reliable, I tend to more encourage Truvada and dolutegravir now, just because I've just been chasing metabolic fatty liver on so many patients. Like I had a guy that new diagnosis 4 or 5 months ago, got him on Biktarvy, saw him last week. He's up 30 pounds and his AST was elevated.
Yeah, thank you very much for sharing that. I think it is so interesting these days, this phenomenon of weight gain, metabolic syndrome, and so challenging to know what to do about it. So I will come back to that, because especially that TDF versus TAF decision, I think is really challenging. And I'll show you a little data why I think it's so challenging. Thank you very much. So the TDF here, the votes for TDF, I'm wondering, is that an insurance coverage issue, or is it really more the metabolic syndrome, weight gain, fatty liver consideration? So can I just ask, before we move to the next part of this, just ask for those of you who voted TDF, what was the main reason you voted for TDF over TAF here? Was it insurance coverage? Because that comes up for me sometimes here in Washington, or was it really the weight and metabolic syndrome issue?
I'll be honest, I haven't really had too much trouble with insurance here. With diagnosis of HIV for PrEP, I have trouble with, if I'm thinking Descovy, I mean, I almost always go Truvada with PrEP, but if I'm thinking Descovy, I sometimes run into trouble with insurance and have to go
Gotcha.
Truvada, but I'm not having too much trouble with insurance between the two.
Okay, that's good to know. We have some challenges here with state Medicaid and Descovy, even for treatment, and for Biktarvy for treatment, but that's good to know. Well, that brought up a lot of considerations we will come back to. I think you had see the results of the poll, correct? Yeah, perfect. Okay, so really brief, I'm not gonna spend a ton of time on this, but the HHS guidelines, which are the ones we mostly go to, were updated in June. Their initial ART recommended for most people with HIV is listed here, not in any particular order. So they give fairly equal weight to Bictegravir FTC TAF, that's Biktarvy, dolutegravir FTC TAF, which is Descovy, or FTC TDF, which is Truvada, or dolutegravir bacavir lamivudine if someone is B5701 negative and does not have hepatitis B. That's the Triumec pill. My experience has been similar to what Stacy shared. I've really gotten away from Triumec, both because it's just not as well tolerated overall in my experience, even for people who are B5701 negative, and it's just a huge pill. And then there's the abacavir cardiovascular controversy, which we can hit on briefly. The guidelines do mention dolutegravir lamivudine, 2-drug initial therapy, that's trade name Dovato. I didn't get any takers for that being the best option. I have to say, I have not started anyone on that as initial ART, and I'm not really convinced that I need to or I will, given that the other options are relatively well tolerated. I'm also a little confused by the guidelines where they have category recommended for most people with HIV, and then they have a category used in special circumstances. And to me, all these caveats around dolutegravir lamivudine are just the epitome of special circumstances. Only if viral load is relatively low, no Hep B, have your baseline genotype results. So I don't really understand why the committee put it here, but I don't know a lot of people using it for first-line therapy. I have transitioned people to dolutegravir lamivudine maintenance therapy, and I do like it for the individual who has taken 1 or 2 regimens, not a lot of virologic failures, no resistance to those meds, and then there's some sort of compelling reason to simplify. I have gone to it, and we'll talk more about that. I have gone to it in that situation. The biggest change as of June was the guidelines committee moved raltegravir away from recommended for most people with HIV and moved it to you consider in unique circumstances. I wasn't using raltegravir much for first-line therapy anyway. I didn't get the impression many people were. It's a well-tolerated medication. These are the reasons that the guidelines committee demoted it, if you will. I think the biggest things are it has a relatively low barrier resistance, certainly lower than dolutegravir or bictegravir. It does add a bit of pill burden. You can give a raltegravir high dose, 2 pills a day option. It's not a lot of more pill burden, but it is a bit more pill burden, but certainly a lower barrier to resistance. And then as we've learned more about dolutegravir and neural tube defects, the data has grown and has been very, very reassuring. And we really are no longer in this window where we were worrying about dolutegravir and neural tube defects. So the way they worded it is there's no longer a reason to choose raltegravir over dolutegravir for people with childbearing potential. So dolutegravir is now back to preferred, is a preferred option in the perinatal guidelines for use at time of conception or use during pregnancy. TAF during conception and pregnancy doesn't have a ton of data, but we did see a big study last year where TAF was started after the first trimester and did very well, and individuals who took it during second and third trimester pregnancy did better than those who took TDF. There were some weight considerations around that, but it did look really effective and safe when started after the first trimester. There's not a lot of data I've seen for conception and first trimester around TAF. So TAF is listed in the perinatal guidelines as an alternative now. And I think the question that often comes up is, well, what if someone becomes pregnant while taking TAF? Should you switch it or not? And I really don't think we know the answer. I think it's a judgment call, a discussion with the person. If the person is tolerating their meds and suppressed and is doing well, I am leaning more towards continue it, but I really think that is an area where we need more data and better guidance. Questions about that and choosing initial therapy or anything I mentioned? Additional thoughts in your experience? I think one of the biggest questions around initial therapy is, are there individuals who would benefit from starting treatment not with an integrase inhibitor? For example, that person who already has metabolic syndrome or has a lot of risk factors for metabolic syndrome, would they benefit from starting a doravirine-based option at onset? We don't know. It's a topic of a lot of discussion. Both of the guidelines, the HHS guidelines and the IAS USA guidelines, have both added language to say no, there is not enough data yet to alter recommendations for initial therapy based on the risk of weight gain and metabolic syndrome, but it is a topic of ongoing scrutiny. So we will see what the future holds. I'm going to show you another case, and we're going to get a little bit into the abacavir controversy, and then the 2-drug therapy and IM cabrolpivirine. And I would love your perspectives on IM cabrolpivirine. But first, let me share this case. So this is someone from my clinic. This is an ongoing case. Actively discussing with him potential switch to 2-drug options. So he's 55. I've known him for quite a few years. HIV diagnosis in 2010, was on efavirenz TDF-FTC till about 2016. So that's the ATRIPLA pill. Overall, he takes his meds. He had one break for about 6 months due to some hectic things going on in his life and worsening depression. We did not document any resistance mutations at that time. So he did have a viral rebound, and the genotype did not detect any resistance. Primarily due to depression at that time, we said, let's get you off the efavirenz, and switched to Triamec. At that point, if I remember right, we wanted to get away from efavirenz. We were trying to stay away from TDF because of renal risk, and I don't recall why we didn't have TAF as an option, but he ended up on Triamec. He's done well on it since, takes it every day. Viral loads are suppressed. You can see his comorbidities there, which include quite a few cardiovascular risk factors, and he is someone who has metabolic syndrome. So let me just pose this question to you. Again, no right answer. I'd like to get your, if I can go to the next poll, bear with me. I'd just like to get your impression. How much do you worry about this? I think you can see it there. Yell at me if you can't, but how much do you worry about abacavir raising the risk of ischemic cardiovascular events, cardiac events, or MI or stroke, basically? Again, no right answer, just trying to get everybody's perspective. And would love to hear your thoughts. Thank you all for weighing in. And you can see the spread there, from not much to a little to a moderate amount. I'd love to just pause and hear your thoughts. Why you voted what you voted. Have you seen a lot of complications of abacavir? Have you not seen any? Why do you worry about it? Why don't you worry about it? Anyone willing to unmute and share?
I think I worried about it less when the other option was TDF and my patients had renal dysfunction, because I think, we were still very wed to the 3-drug idea, at that time. And if they really couldn't do TDF, it was kind of like choosing between, 2 things that were not great. I think now that we have safer options, I think about it a little more often, because I don't know. I mean, and I don't think anybody really knows, but I mean, we think that there's this correlation. And I think that since I have other options, including 2-drug regimens or TAF regimens, I am trying to get people off, especially ones that have a strong family history, other things like diabetes and smoking and such. So I put a moderate amount, but honestly, it's not because of a lot of personal experience seeing it. It's really more, I mean, yes, there have been some patients, but can I attribute it to abacavir? I don't know, but it's really more because I have other options.
Thank you, Stacy. All those points very well taken, considering the option. Sounds like in your practice, though, you haven't clearly seen young individuals with no risk factors except abacavir developing MIs or strokes.
Brian, this is Amy. I have a case.
Hey, Amy.
Hey,
Tell
sorry,
us.
I just got out of clinic, so my video's off at the moment in transit. But yeah, I had a patient a couple of years ago that I'm so glad I documented the conversation in December, the 8 months before, about abacavir and just some of the concerns. And he was a smoker and didn't want to change his regimen. And 8 months later had a cardiac arrest. I just saw him like yesterday, so he's still with us. But boy, it was just one of those cases where, you know, it definitely struck me and made me wonder. He certainly is not on abacavir anymore and had other risk factors, of course, that may have contributed, but that anecdote still sticks with me. And just another fun fact is, you know, he and another one of my patients actually had an MI in short order. Both got put on Plavix and were on protease inhibitors. And 2 weeks after their discharge, we discovered the interaction and called cardiology to say, do not use this with our patients with MIs. So use something else. But anyway, thanks.
Amy, thank you for making time to be with us. Glad you're on. Thank you for sharing that anecdote. Those anecdotes do stay with you. I have to say, this isn't a phenomenon I've witnessed a lot in my clinic, but we have had a couple within our clinic, not necessarily my patients, but within our clinic, of young people without a lot of risk factors taking abacavir who've had MIs, and those anecdotes have stuck with me as well. Also, to your Plavix story, that's come up for me a couple times with the DOACs lately, where people taking protease inhibitors, hospitalized and discharged with DOAC, and there's no review, and then we catch it in clinic. It's one of the ones with interaction. So I think that's just a reminder to keep an eye on that. So I appreciate all of the thoughts and comments. I'll share, I think over the years, I've moved a little down this spectrum from skeptical and maybe worrying a little to probably now a moderate amount. I'm not going to show you a ton of data. This is a brief summary. I mean, I think the reason this is controversial is if you go back to all the randomized clinical trials of abacavir, there was no real signal for more MIs, more cardiovascular events. But I think we have to keep in mind that RCTs include very carefully selected people and short-term or a finite amount of follow-up. And we don't always see these things until after the drugs are approved and we get longer-term clinical experience. If you look at the observational studies, if you look at the systematic reviews, they often do find an association, a correlation, as Stacy said, between abacavir and ischemic cardiovascular events. The challenge I find is if you look at those, some of them find a correlation between current use of abacavir, some of them cumulative use, some of them, including a big one just presented last week, it's only recent use, only within the past 6 months. So what do we do with that? How do we translate that to clinical practice? I think that's an important question. My practice, similar to what was mentioned, is for people taking abacavir to at least sit down, think about it, think about the risk factors, and think about the other options and have a conversation. And if there are other safe options that are likely to be well tolerated, likely to keep the viral load suppressed, I have a low threshold to get people off abacavir just to get away from this issue. The other thing is, in the past couple of years, we've seen more about the mechanism, and I think it's become more biologically plausible that this is a true phenomenon. Before, we always kind of felt like, okay, there's a correlation, but why would that happen? But now, not just one, but multiple studies have found that abacavir does activate platelets, promote reactivity. It really changes, it causes this kind of reactive inflammatory platelet milieu, if you will. And I think that really gives us a biologic basis to say, okay, this correlation could indeed be real. So again, translating that to clinical practice, for me, it's not get everyone off abacavir. I've seen a number of people, like the patient I presented to you, who've taken abacavir for years and been fine. But if there are additional cardiovascular risk factors, if there are other effective options, then I do have a low threshold to switch it. So let me pick your brain on this one too. So the person I showed you previously suppressed on efavirenz FVC TDF, one break in viral rebound, but we didn't catch any resistance on the genotype. Now taking dolutegravir back to imivudine for about 5 years with cardiovascular risk factors. So let's say insurance isn't a barrier. what would you recommend? He says, I'll take whatever you recommend. And again, let's pretend insurance isn't an issue. In reality, at least here in Washington, I am finding insurance sometimes to push back on these 2 drug options, and sometimes I have to give them separated into 2 different pills, but it's not a huge difference. So continue the dolutegravir, baclofen, lamivudine, maybe wait for future options, switch to BIC, FTC, TAF, Biktarvy, switch to dolutegravir, rilpivirine, the 2 drug combo, which is Juluca, switch to dolutegravir, lamivudine, which is Dovato, switch to IM cabopivirine after an oral lead-in, or if you do something else, please feel free to jump in with something else. And thank you to everyone who voted. So, Biktarvy or Dovato? I appreciate the votes, kind of where I was leaning to. I really don't think there's a right answer here. I actually have sat with this patient and presented him these options and talked to him about all of them, and we're still kind of thinking about it together. Anyone want to share why you chose BIC, FTC, TAF, or dolutegravir, lamivudine? In a couple of years, we'll be asking Augie his opinion.
I think he's already on Triumeq, so you're just dropping a Bacavir. So you already know he can tolerate what he's on versus switching him to. I mean, he's been on FTC, but you're putting him on. He's never been on TAF. He's never been on Biktarvy. So you can do the same thing with less medication. So
yeah, I like that argument a lot, Chris. Point very well taken. You're not giving him anything new. You're just dropping something, giving him a smaller pill without the risk, and he's been suppressed for a long time. We don't think he has resistance to dolutegravir, lamivudine, so I think that argument makes a lot of sense. Welcome. I saw Vinny jump on. Vinny, great to see you again. I feel like it's been a long time. Thanks for being with us. So let's talk a little more about these 2 drug options, and then we'll pause, get your thoughts again, especially on the cabopivirine situation. So the guidelines do support 2 drug maintenance therapy for carefully selected individuals. So not for everyone, but for those people who have taken their meds, have suppressed viral loads, don't have resistance to the 2 drug option, and importantly, don't have chronic hepatitis B, because none of the 2 drug options will treat their hepatitis B. I think we can consider switching to 2 drug maintenance. The options that are outlined in the HHS guidelines and that have the strongest data are these, so dolutegravir, rilpivirine, or Juluca. And you can see here the criteria for who got into the study, which I showed us to give you a sense of who's being considered for these maintenance 2 drug medications. Also dolutegravir, lamivudine, trade name Dovato. The others that are highlighted by the HHS guidelines that don't have as much clinical data are boosted PI plus 3TC, or boosted darunavir plus dolutegravir. That 2 drug combo, dolutegravir plus darunavir cobicistat, is a 2 drug option I've used for several individuals who had a lot of NRTI and NRTI resistance, but suppressed viral loads for a long time and full activity in those classes. And there was a clinical trial called Dualis, published in OFID last year, that looked at boosted darunavir, dolutegravir 2 drug therapy versus a 3 drug option. People did quite well. It was under 300 people in the trial, so it wasn't as robust as with dolutegravir, rilpivirine, dolutegravir, lamivudine, but I think for certain people it can be a good option. It does have the downside of being a boosted protease inhibitor, of course, and has the GI side effect risk, the drug interaction risk. The other option that comes up sometimes and isn't mentioned in the guidelines, I would say yet, is dolutegravir plus doravirine. 2 drugs, not a lot of interactions, pretty well tolerated for individuals with suppressed viral loads who have full activity of doravirine, full activity of dolutegravir. We think it should work. There's no reason to think it wouldn't work, but there's not a lot of data yet. So these are some of the outstanding questions that I think of when I consider these 2 drug maintenance ART options. I've heard people argue that we really should be doing this more. I think I'm still in a phase where I default to 3-drug ART and then think about specific cases and think about, okay, do you qualify for 2-drug ART? But there are people out there arguing that we should be doing more 2-drug therapy even up front. I'm not quite there yet. The long-term benefits of these 2-drug options compared to the 3-drug options with TAF, I haven't seen anything convincing that there are huge side effect benefits to avoiding the TAF. But I think we need more data, more time. The dolutegravir rilpivirine option was compared only to TDF combinations. It hasn't been compared to TAF as far as I've seen, so we don't really know how that compares. Dolutegravir lamivudine was compared to dolutegravir with TAF FTC, so we do have a comparison with TAF FTC, and there really were no clear side effect benefits to avoiding the TAF, but I do think that, sometimes less is more, and avoiding TAF, avoiding NRTI can be beneficial for the person in whom it's likely to be effective. So just food for thought, things to be effective. I mentioned, I think we need more data around dolutegravir doravirine. Who are the best candidates for IM-CAB rilpivirine? We'll turn to that next. The other thing that was a big topic of conversation at the ID Week conference recently was, well, what about the person who may not be an optimal candidate? Would you use IM-CAB rilpivirine, and what are the risks? And then there are a bunch of 2-drug combinations with new medications coming. So if a person is not an optimal candidate right now, should we just wait? And I'll mention briefly a couple of things that are coming. I won't be showing a lot of data on those, but I'll mention a couple of things briefly. But let's talk about IM-CAB. I'm going to do another poll here because I'm very curious to ask you this. How many of your patients or clients currently receiving Cabenuva, the long-acting every month IM-CAB rilpivirine? I will share that for me and my patient panel, it is currently 0. I have talked with people about it and do not have anyone currently receiving it. And in our clinic, it is still a very small number. And it seems like I'm not alone. So I think this is a really interesting scenario in which we have our first ever long-acting ART regimen. We were so eager for that. We waited for it for so long. It was so exciting to hear it was coming, and now no one's receiving it. And so I'd love to hear your perspective on why that's the case. Maybe I'll just show you a couple things and then open the floor, and would love to hear your opinion on that and your experience talking with patients about it. This is from the National HIV Curriculum, and if you want to get into the data, we have slides on all of these trials, but these are the phase 3 trials just so you can see what the long-acting intramuscular CAB rilpivirine has been compared to. So it's been compared to daily oral dolutegravir bacteremia lamivudine. It's been compared to daily oral other standard 3-drug regimens. And then every 4-week injections has been compared to every 8-week injections. And I'll show you one thing about that because the FDA is reviewing that data right now. And this is what the FDA says is the indication for IM-CAB rilpivirine. So replacing regimen, somebody with suppressed viral load, taking a stable HIV regimen, no history of treatment failure. I think more importantly, no known or suspected resistance to the 2 drugs in the combination. And again, no hepatitis B, which is true for all of our current 2-drug therapy options. So I'd love to hear your perspective. Why haven't we used this more? I think for me, it's been a combo of, I talk to patients about it and they sound interested, or they are interested in the idea, but then when I say this requires a visit to clinic for an injection, not an injection, 2 injections in the butt every month, they say, no thanks, I'll keep taking my pill at home every day. Or they're really interested, but they had NNRTI resistance. That's come up for me a couple times, and I don't feel comfortable because of the rilpivirine. Or maybe they're interested, but these are meds with a low barrier to resistance, and I feel a little hesitant as a provider if they're going to make it every month and what might happen when they miss. So for me, it's been a smattering of those three things, I guess. But what's it been for you? Stacey, you mentioned you have a couple people who might be starting it. To Jeff Jansen, I see you also unmuted there. Maybe actually to Jeff Jansen, if you'd like to share a question or comment, please do, and then Stacey. Jeff, I noticed you unmuted. Anything to share there? May not have been intentional. Stacey, go ahead.
Yeah, so the first one that came up is actually one that Michael Stevens and I share. So it was a patient that I saw at Billings Clinic, then she picked up and then now has come over to Riverstone because we're looking at possibly doing Cabenuva. And I presented him to you guys, Echo, actually, because he was the gentleman who just had a lot of trouble taking his pills, had a lot of trouble taking care of himself, and has AIDS and has had recurrent or relapsed lymphoma. So he's just got a lot going on, and he really is very interested in doing this because he feels like it would allow him to have better control without having to be so stressed about taking the medications every day. Unfortunately, he has a pretty resistant virus, but he's never been on a rilpivirine regimen that we know he's failed. And then when we did the GenoSure archive, he looks to be a candidate. So we're hoping to get him started soon because he was definitely the one that even a year ago was at my door being like, I want to do this. And I told him 2 injections every month for now, maybe eventually every 2 months. And he was like, that's fine. Like he just really wants to do this. So I think we probably will move forward with that. I think at our clinic right now, we're still trying to figure out the he's Medicare and how do we do this? How do we get the meds here? How do we do this? I have enough. So all 3 of ours that are interested have very different backgrounds. So the second one is actually someone who is very open about the fact that he uses IV methamphetamine a lot. And when he uses his IV methamphetamine, he does not take his meds. And it's not because he doesn't want to, it's because he just doesn't remember to take his meds. And he also gets very anxious about the fact that he's not under great control and would like to be on something that gives him long-acting coverage. Now we get nervous about even being able to track him down to bring him in once a month or every 2 months, and especially with a low barrier to resistance medication. And I have a third one that is probably going to do it as well, but a very, very different story. He's awesome at taking his medication, but has familial polyposis syndrome, has had a colectomy and some of his small bowel removed, and has short gut syndrome. So he's often running these mild viremias, probably from absorption issues. And he just really was interested in the thought of having an injectable medication because it gives him more control. He doesn't absorb his other medications very well. So I think we've got 3 good candidates, but for different reasons. I think the one who uses IV drugs makes us a little more nervous. But to your point about why have we not done this more? The people who are really good, you have to be undetected to even make this switch. And the ones that are really good at taking their medications, by the time they get really good at taking their medications, they're like, well, this is not so bad. And then you're like, well, yeah, okay, so you can carry on with what you're doing. It's the ones that are like, yeah, I can do this for a short term, but I know I'm not going to be able to carry on, being so good with my medications in the long run, are the ones that, we're kind of looking at as more appropriate candidates for this. I would also be interested, I'm going to stop in a second so other people could comment, but I would also be interested in hearing people's thoughts about this oral run-in though, because that has also stopped me from being very ambitious about this because, for example, my 2 patients, the first 2 I spoke about, they have a lot of trouble taking their pills. And even though they're on regimens that they are well controlled on at this moment, being eager to get onto Cabenuva, I have a real problem switching them over to oral cabotegravir and rilpivirine that have a lower barrier, to resistance for that month leading up to it when I know that they're not great at doing it in the first place. It makes me anxious, and particularly in my patient who can't absorb medications very well. Why would I do that? Why would I even do that? And so I am curious, in that gentleman, I'm almost tempted to jump right into giving him the injections without doing an oral lead-in. I'm going to probably try with the other 2 to do the oral lead-in, but it makes me nervous. So that's enough out of me.
That was great. Thank you, Stacey. I do have a little update here in a bit on the oral lead-in. So that's a really good question. And the guidance on that may shift soon, but just coming back to your considering who to offer and prescribe this therapy to, I think you hit on varying scenarios where there may be benefit and some of the varying concerns. So would love to hear from everyone else as well. How has it gone talking with patients about this? What have the barriers been? Jeff
Yeah,
Jaden?
I think the area that I've seen is, again, I agree with sometimes it's an adherence issue, and then trying to do the oral lead-in and things there, I'd be concerned that are you selecting for resistance, or is it not going to be as effective and things. And then when we come to the discussion of how often you have to get the injections, I think if they got it to 12 weeks or a longer period of time, I could see that. But when they want to come in for monthly injection, then they're like, oh, I'll just kind of take the pills and things. But I think if you offered it, it's 3 months or longer, then I could see that there may be that they could rationalize or kind of grasp on that a little bit better. But those are some of the issues I've seen.
Yeah, totally agree, Jeff. I am not optimistic it will ever get to 3 months. When these drugs were initially being developed, the hope was for 3 months, but the PK data just didn't support it. I am optimistic we'll get to 2 months, but not sure about 3. That said, there are other options coming that may be less frequent than that, but all of your points are very well taken, and these are really important considerations. The other thing I think we just don't know is what is the risk of missed doses. And frankly, I don't think anyone has enough real world clinical experience to know. And so I think that collectively we need to be sharing experience. Stacy, if you get 1 or 2 or 3 people going on it, I would love to hear and learn from you, your experience. I'll talk a little more about data related to these things and the lead in, but really I'm not talking about this because I have the experience to know the answer here and what the risks are. I think we all need more collective experience to learn that. Other thoughts, perspectives, conversations about Cabenuva with patients? Let me show you a couple things and I'll pause again and see if it triggers any additional questions, ideas. This is the recommended per the FDA and the prescribing info administration. So right now, a 28-day oral lead-in is recommended with oral versions of the drugs. Again, we're really selecting people with suppressed viral loads, doing the lead-in to make sure they tolerate it because these are long-acting agents, then doing this initial injection with a higher dose and with monthly injections, reducing the dose. If we end up going to every 2-month dosing, if the FDA ends up approving that, it will probably be, the dosing will probably go to 2 months, but stay at this higher dose. It'll probably be a different dosage recommended. There is a trial ongoing called Latitude that is enrolling people with not suppressed viral loads and giving them, but they are still giving oral ART up front to get the viral load suppressed before going to injections. They're not going right to these injections with a detectable viral load. That study is basically giving people incentives, financial incentives to take their oral ART, get their viral load suppressed, and then switching. So we may learn something from that trial because that trial is enrolling individuals who have struggled with adherence, who have detectable viral loads. Really the people in whom we might not feel fully confident about Cabenuva. So I think we may learn from that study, but I haven't seen any data yet. I think you're absolutely right. It's a bit of a catch-22 here where we have our first ever long-acting HIV meds. It's great, and we'd love to offer this to people who really struggle with pills, but these are low barrier to resistance meds. And we also, at the same time, really worry about missed visits, missed doses, and what could happen, and the risk of creating more integrase or NNRTI resistance. So it's a tricky situation right now with these. The FDA did give guidance for planned or unplanned missed injections. I'm not going to go through this, just so you know, it's out there if you get someone started on this and this comes up, as well as what to do after or greater than 2 months since their missed dose. So again, I don't want to go through this in detail, but just know that it's there if this becomes relevant for you. This is the comparison of every 8-week to every 4-week injections. They were equally effective. So I suspect the FDA will end up approving every 2-month dosing. I don't know if they will give any guidance around who may qualify, or let me say that a different way. I don't know if they'll give any guidance around offering 2 months for specific individuals or 1 month for others. I've heard a couple of experts around the country say, well, they're going to start everyone with 1 month, and once you're doing well, spread out to 2 months. And I don't know if that will be officially recommended or will be the strategy, or if we will be able to recommend for everyone doing every 2 months. I could see, asking someone to come in every month, just keep a close eye on things up front, maybe having some benefit, and it may just be a case by case judgment call.
Ryan, is that the same dose every 2 months?
Hey, Vinny, so the dose, so right now.
I mean, is the dose the same 1 month versus 2 months?
So it's not, Vinny, thank you for asking that. It's different. So my understanding is right now, this initial loading dose, 600 of CAB, 900 of rilpivirine, then drops for the 1 month dosing, but for 2 month dosing will not drop. Will basically be the same as this loading dose every 2 months. We'll confirm that once the FDA actually approves it, but that is my understanding of the way they studied it.
Good, thank you.
Yeah, thanks, Vinny. So I suspect every 2 months will be approved. I don't know the details though of whether they will add any more guidance around it. So questions about long-acting rilpivirine, some of them we have raised for sure. Other things, I think the logistics, the insurance coverage, administration, I think a lot of centers and clinics have spent time trying to sort out. I know our pharmacy team has spent a lot of hours sorting out how to do this so that when we're ready, we can. There have been discussions about who is at higher risk for virologic failure with this option, and some data that certain individuals may be at higher risk. In the clinical trials, a fair proportion of the virologic failures that happened were in people with subtype A virus. Subtype A is mostly in Russia and Eastern Europe. It's pretty rare, less than 1% of the HIV infections in this country are subtype A, but that does seem to raise risk of virologic failure, probably because with that specific subtype, there are higher rates of this cabotegravir polymorphism, this L74I, that affects cabotegravir activity a bit. So, it's been discussed, should we be doing DNA or archive genotypes on all these people who are suppressed, and either, make sure we know their subtype or make sure they don't have any polymorphisms. I don't know anyone who's strongly recommending that, but if you were to see someone in your clinic where, you weren't really sure their ERT history, or you had some concern about, possible past imperfect adherence on integrase or NNRTI, I might do a GeneSure archive at that point and just be sure. Or if you do see someone in your clinic with HIV who's moved from Russia or Eastern Europe, and is more likely to have subtype A virus, then I might look at their subtype, then I might look at a genotype and confirm that. There was some early data that elevated BMI might be predictive of risk of virologic failure. I've seen more recent data refuting that. And there was just a paper published that looked at all of the phase 3 RCTs of IM cabotegravir and compared BMI over 30 to BMI under 30, and there was no difference in virologic efficacy. So I feel more reassured and wouldn't consider that to be a contraindication. The way they put it in that study was there was no one with virologic failure where that was their only risk for virologic failure. So again, roll for every 8-week dosing. It's being reviewed by the FDA. Risks of missed injections and how we're going to tackle missed injections, especially if we can't reach people. We just don't know. Is the oral lead-in necessary? So hot off the presses, Stacey brought this up, so I'm not sure if you saw this, but interesting paper by Chloe Orkin from the UK and others, where they looked at individuals who were switching to IM cabotegravir. This was the open label phase of the FLAIR trial. So they basically did the RCT. Everyone in that had to get oral lead-in. When they finished the RCT part, and then they open this open label phase, which is what they often do, and then they just let people select. They just let people pick, hey, do you want to continue oral ART or switch to the injectable? And interestingly here, for those switching to the injectable, they let them decide, hey, do you want to do the oral lead-in or not? And these numbers aren't dramatic. 121 opted for the oral lead-in, 111 didn't. They did what's being termed direct to inject. And the punchline is 24 weeks later, they all did fine. There was no increase in side effects or issues. And we know that, or we suspect that with IM cabotegravir for PrEP, the oral lead-in is going to be made optional. This would argue that for IM cabopivirine for treatment, it also could be optional. And the European Commission, which is their equivalent of the FDA, it sounds like is going to make the oral lead-in optional even for IM cabopivirine for treatment. I don't know if the FDA is going to change their recommendation on this. I don't know if they're reviewing this data, but this would argue that the oral lead-in for treatment may not be nearly as necessary as we thought. I think that's what I had to say about Cabenuva. Questions, comments, thoughts, reflections? What do you think about that? I'm gonna pause there for a sec.
Did they recommend any type of a trial of that in case there was any type of an adverse effect or anything prior to the injection, or nothing?
I missed the first part of that, Jeff. A trial of the oral, you mean?
Yeah, I just was wondering if they recommended any form of giving the oral prior to see if there's any adverse effect before the injection.
I don't think they did in this study. I think they went right to injections, which, you know, on the one hand could be pretty nerve-wracking because these drugs last in the system for months. On the other hand, these are such well-tolerated drugs that I think they just said, look, you know, there's pretty low risk. So the way I read this paper, Jeff, no, they did not do any oral doses for the direct to inject group. I suppose, you know, we could use our judgment and talk with people and say, hey, well, maybe 4 weeks of oral lead-in, maybe, you know, maybe that's going to be too much, but maybe a week or maybe 2 weeks just to make sure you know, don't have any immediate side effects. I mean, maybe that would be reasonable, but this is pretty new data, and I don't know how this is going to be incorporated into practice or whether the FDA is going to incorporate it into their guidance.
Hey, Brian, are we still going to have to get the oral cabotegravir from the pharmaceutical company? They're not going to make that commercial, are they?
I have not heard anything about that changing. I can't say I know that for sure, but I have not heard anything about that changing. Yeah, great questions. Other thoughts, questions? Let me just show you a little bit then about what's coming before we turn to other topics. So I'm going to explain a couple things here because I think there's a few notable things, and this is not an exhaustive list about what's coming, but took this from a talk from Melanie Thompson because I thought it was a good summary, and I added a few details. So for the long-acting cab and rilpivirine, so we've discussed the monthly was approved. The every 2-month dosing we should hear about by late December. IM cab for PrEP, which I'll talk more about in the PrEP part of this discussion, we should hear about by late January. So IM cab for PrEP is definitely coming. The other thing that these discussions often come back to or bring up for me is, well, if we can get rid of the requirement for coming to clinic every month, I mean, maybe it would be more palatable for a lot of people. I'm not aware that the long-acting rilpivirine is being developed in a sub-Q formulation, but the cabotegravir definitely is. It's in phase 1 right now. So I would posit that IM cabotegravir will be approved for PrEP early 2022, and then sometime in the future, within the next couple of years, there may be a sub-Q option for that. The other new drug that I think is worth knowing about is lenacapavir. It's a capsid inhibitor, so a totally new mechanism of action. So on the one hand, will be an option for people with extensive multi-class resistance, people, you know, the individuals who have no other options. So it's exciting for that reason, but also it is very long acting and is already, let me say that a different way. And it was formulated from the beginning as a sub-Q every 6-month formulation. The treatment experience data for lenacapavir has been submitted to the FDA. So the FDA is going to review that. I haven't seen an exact date when they'll weigh in on it, but lenacapavir may be approved as an every 6-month sub-Q option for heavily treatment experienced people within the next 6 to 12 months. In that study, they basically took people with detectable viral loads, very few ART options, and gave them sub-Q every 6-month lenacapavir with an optimized background regimen, basically as many other agents as they could that had any activity. And people did well as long as they had one other active drug. So lenacapavir plus one other active drug, people seem to do well. It wasn't a huge study, but for those people where there's just so few options, this will give us another one. Stacey, I can't help but wonder, could this, for your person with IM, CAB, rilpivirine, where there's a little nervousness, could this be another option to add to that, a sub-Q dose every 6 months? I don't know. I don't know what access to the drug will be like or what cost will be like, but I think it is coming in the relatively near future. And so it also will be an option for PrEP as a sub-Q with every 6-month dosing. And then it also as a pill is dosed weekly. And there's a trial looking at switching suppressed patients to weekly dosing of lenacapavir with islatravir, which I'll talk about next. So there are definitely new things coming in terms of fully new class, long acting with sub-Q dosing, as well as a new oral 2-drug option that would just be weekly. Exciting to have a weekly oral option. And the other thing is these seem like very metabolically friendly agents. The lenacapavir, as well as islatravir, and then islatravir is going to be combined in a pill with doravirine as a 2-drug option as well. These all seem much more metabolically friendly than the integrase inhibitors. So I think the next couple years will bring more long-acting options, more 2-drug options, and hopefully some more metabolically friendly options. Before I pause for thoughts and questions on this, islatravir is an interesting drug as well. They're calling it an NRTTI for nucleoside reverse transcription translocation inhibitor. So it blocks a specific step in reverse transcription called translocation. Has a couple other methods of activity as well. So working basically on the same target as our NRTIs and NRTIs, but in a different way. And so it will be also a new class for people with a lot of experience and also very long acting. So you can see here, oral weekly in 2-drug therapy, oral monthly for PrEP, and then oral weekly combo with lenacapavir as well. Oh, and then this is probably most exciting about this drug, a yearly implant for PrEP. So a once-a-year implant. So lots of exciting things coming. Again, this is not an exhaustive list, but I don't think that IM, CAB, rilpivirine is the panacea in long-acting agents, and I think we might get more mileage out of some of these things that are coming in the future. But that was a bit of a mouthful about those. Questions or thoughts or reflections?
So Brian, did you say that the PrEP with cabotegravir, is that just cabotegravir then? That's not like the rilpivirine with it?
Correct.
So oh, that's awesome. Okay.
Correct. And so for PrEP, it is only going to be cabotegravir, both for the IM option and then also for this sub-Q in development. IM rilpivirine had some very early PrEP studies and then was abandoned for a combination of reasons. One of them being a published case where a person without HIV got IM rilpivirine, and then many months later contracted HIV and developed pretty significant NRTI resistance because it was still in the system at a low level. I mean, these drugs, CAB and rilpivirine, when given IM, last in the system for 6 to 12 months or more. And I don't think that was the only reason it was abandoned, but that case made some headlines and I think was one of the reasons. So for PrEP, it will be IM cabotegravir alone, and then hopefully sub-Q cabotegravir in the future.
And I love that yearly implant. We're never going to get STI screening on those patients. We're going to put it in and they're going to disappear. But that's okay.
Point taken. Yep. It will not be perfect. We will have to come up with a way to address that. And one of many reasons we need good options for like every 3-month home STI screening and things like that. But your point is very well taken. Other thoughts on new drugs or long-acting drugs? When we get to PrEP, I'll talk more about cabotegravir. I think I have a lot on the implant, but I'll at least show you a picture of it. And why don't we talk about weight gain for a moment? This is one of the murkiest and most controversial topics these days. And I'll share a little bit of data. I'll share my take, and then would love to hear your perspective as well. Certainly something that is still evolving and we're learning about. So another real case from my clinic. So this is a 40-year-old woman, initially born in sub-Saharan Africa, immigrated here. She'd been diagnosed with HIV in her home country back in 2015, had taken NNRTI-based therapy, so standard therapy at the time in her home country, moved to the US in 2019, and ART was switched to first-line therapy here because we tend to do that and we tend to think it's better. And then since that time, her viral load has been suppressed. We don't know much about her labs or any past resistance in her home country, but as far as she knows, she took her meds and didn't have any resistance. But she has gained a documented 30 pounds, and when you track her weight in the chart, she has she is bothered by it, bringing it up, and it is true, she has gone up. That said, her diet has changed. She's fairly sedentary. There are certainly other factors. You can see there the comorbidities. So current ART is dolutegravir, FTC, TAF after receiving an RTI-based therapy. And I would love to know, if I can find the next poll. I would love to know what you would do. And I gave you a lot of options here. So I gave you the options of continue current therapy, switch her dolutegravir to doravirine. So she'd have doravirine, FTC TAF, so get her off dolutegravir. I gave you switch to dolutegravir, FTC TDF, so get her off dolutegravir and get her off the TAF. Nope, I said that wrong. Dolutegravir, FTC TDF would just get her off the TAF. Then the next option, doravirine 3TC TDF would get her off both, get her off dolutegravir and get her off the TAF. Go to dolutegravir 3TC, simplify and get her off the TAF, dolutegravir rilpivirine, or something I didn't think of. So give you a second to digest that and weigh in. Definitely no right answer here. So give it a few more seconds. All right, thank you for everyone who voted. No right answer, and clearly there are lots of options and there is no crystal clear guidance on what to do here. So vote for continuing, vote for getting her off TAF, vote for getting her off both dolutegravir and TAF, vote for simplifying. Okay, so I love this because I think it shows that we really don't know what is best here. So I'll show a little bit about why this is coming up. I'll show you some very new data and give you my take, but it is not guidelines based. It is just my take. So I'd love to hear your perspective as well. And this is certainly evolving. So we have learned in recent years some of the risk factors or predictors of weight gain with either starting or switching ART. Language has now been added to both the IAS USA and the HHS guidelines about this. I'm showing you the language from IAS USA because they added it first, but the language in HHS is very similar. So we know a lot of people gain weight when they first start their ART. Part of that's probably healthy. Part of that is probably return to health, suppress the viremia, suppress the catabolic effects of untreated HIV, help people get back to health. The issue is some people continue to gain beyond what we would consider a healthy weight and seem to be at higher risk of developing complications like metabolic syndrome, diabetes, and related things. Not everyone, but somewhere around 10 to 20% of people do gain an excess amount of weight with initial ART. Some of the predictors of gaining excess weight include Black or minority race, born female, and then the association with ART is getting dolutegravir or bictegravir. In most studies seems to be associated. In some studies, the other integrase inhibitors. And then getting TAF compared to other NRTIs seems to be associated. The long-term consequences are unknown. Again, this doesn't happen for everybody. How exactly to predict this is very challenging. And then what to do about it is a huge, huge question. And what we don't know, though we are learning, but what we don't know is the exact mechanism. And what we don't know is, well, if this happens and you switch the ART, does it reverse? Is that better? So lots to consider and think about here. This is, the graph is just to show you what happens with switching TDF to TAF. I may have shown this a year ago when we met before, but just as a reminder, time zero here is switch TDF to TAF. The different colored lines are the different anchor drug. And what this brings up to me is people do tend to gain with the switch. Average is about 2 kilograms, 6 pounds and change. For most people, it then levels off. So for most people, it really stabilizes after 9 to 12 months. So whatever mechanism, whatever biologically is happening here, for most people does seem to level off. And so again, how can we translate this into a message for patients? How can we know what's best to do? And should we be getting people off of TAF? Should we be getting people off of integrase inhibitors? I think we just don't know. I do think it is interesting if you drill down and look at all of the ARVs to do comparisons. So this big study that Paul Sachs led looked at a number of ACTG trials of initial ART and compared basically all the meds. And yes, the integrase inhibitors did lead to a lot of weight gain, but also rilpivirine led to more weight gain than efavirenz. You can see here the spectrum amongst the NRTIs. And so it's not an easy, hard and fast, like integrase inhibitors are worse, TAF is worse. I think there's a lot of data now showing that efavirenz actually suppressed weight more than we realized. And people who are quote unquote slow metabolizers of efavirenz gained less weight. The higher efavirenz levels suppressed their weight before a switch. So if someone was taking efavirenz and was a slow metabolizer, meaning they had high drug levels, and then they switched to an integrase inhibitor, they gain even more weight than somebody who had low efavirenz levels because the efavirenz was suppressing their weight before the switch. The same seems to be true with TDF to TAF. TDF seems like it suppresses weight more than we ever realized or understood. And I'll show you a couple of points of evidence there. So here in the Gemini trial, which I think is an interesting comparison. So this was a study that looked at dolutegravir 3TC as initial ART compared to dolutegravir FTC TDF. So again, this was initial ART. So the only difference here is whether you have TDF or not. and those who got TDF gained less weight. And so if you put TDF in a regimen, people gain less weight. And if somebody's on TDF and they switch to TAF, they gain weight. But is that TAF causing weight gain, or is that TDF suppressed weight gain and you're removing that effect? I think is a really important question. And I think we need to understand this better before we start pulling everybody off of TAF, because TDF has other risk factors. And so I think that, again, trying to take this really controversial, complex topic and translate it into a message for that patient sitting in front of us is challenging. And so the things that I think about are, okay, you know, does this person have other reasons they've gained weight? Are they working on lifestyle? Of course, I always encourage that. Are they having any complications of their weight gain? Is this person developing signs of insulin resistance and metabolic syndrome? And is this something we need to, you know, really get on? And then, similar to what we were talking about before with the Bacavir, what are the other options? Are there other options that will be effective, be well tolerated? Because maintaining a suppressed viral load is paramount here. When someone has gained a lot of weight and developed complications, I have a conversation about switching their integrase to something else, something like doravirine. I tell them we don't really know whether that's the right thing to do, but I have done that on occasion. I'm not doing that for everyone. The TAF versus TDF switch, I have struggled with, because I think that TDF has more bone toxicity, more renal risk, and I think it might be suppressing weight for reasons we don't understand. So I personally am a little more hesitant with that switch when people have gained weight, but I am in no way saying that's the right answer. Let me show you a little bit more that's kind of hot off the presses, and then would love to hear your thoughts. So this is a look at PrEP, and is a look at oral FDC TDF compared to IM cabotegravir. And I think what's really interesting here is if you just look at the overall data, it looks people gain more weight on cabotegravir. They do. And if you just look at that, you might say, okay, cabotegravir, it's integrase, you know, people are gaining more weight because of integrase. But if you actually drill down, the reason there's that difference is primarily weight loss from TDF within the first 40 weeks. And so it really was TDF weight loss or weight suppression driving that difference. And then what we just saw at ID Week a couple weeks ago, which I thought was really notable, was this review of all of the PrEP data. And what you see here on the right, so this is odds ratio of 5% or more weight loss, not weight gain, weight loss. These top bars are comparing TDF to placebo. I think you can see my cursor. These top bars are all TDF compared to placebo. This bar is TDF compared to cabotegravir. And this bottom bar is the cumulative data. And what you can see here is in all of these instances, TDF is leading to weight loss. There's no comparison directly between TDF and TAF here, which I think is unfortunate. But when you compare TDF to placebo or TDF to cabotegravir, TDF leads to weight loss. Now, why? Is TDF causing a bunch of GI side effects? They tried to look at this, and TDF did lead to greater odds of vomiting, but no increased odds of nausea, diarrhea, or loss of appetite. So I don't think we can clearly say that people lose weight on TDF because of GI side effects. So I worry there's some degree of mitochondrial toxicity. It is an NRTI from TDF that we just don't fully understand. And I want to know more before I routinely recommend people who've gained weight switch from TAF to TDF. The other thing we saw at CROI that I thought was really notable was this study, and it's a mouse model, and I don't get really into mouse models very often, but with the weight change issue, kind of like with abacavir, I really want to know the mechanism. I really want to know that this association is biologically plausible. And what this group from Johns Hopkins did was they injected mice with dolutegravir, bictegravir, or doravirine, and then looked at the fat cells, and with scientific methods that are above my head, looked at the fat cell differentiation. And importantly, the integrase inhibitors, the dolutegravir and bictegravir, had effects on the fat cells directly. So they induced differentiation of a certain type of adipocyte and led to lipid accumulation. And then they basically uncoupled the mitochondrial process and energy consumption and energy burning in this other type of adipocyte, which doravirine did not do. So I think there is growing data that integrase inhibitors may lead to weight gain and insulin resistance hyperglycemia directly, whereas doravirine and other agents don't. I think there is growing and pretty convincing data that TDF leads to weight suppression and weight loss, as does efavirenz. Does TAF directly cause weight gain? There's no proof of that yet, but I think we just need to know more before we have cut and dry protocols around what to do here. So before I ask you your opinion, this is just my opinion and my strategy. This is my interpretation, and I've told you these things. I think it's also important to note that not everyone gains weight like this, but when people do, I think we need to be able to talk to them about it and talk about options. I also think we do not understand why the weight change with an ART switch seems to happen in the first 9 to 12 months and then level off for most individuals. I also don't think we know what happens when you switch ART and what things reverse and what don't. I've seen case reports of people who switched to TAF or switched to integrase and then developed metabolic syndrome and diabetes, and then it reversed when they went back, but it is case reports. That is the level of evidence right now. So my strategy really is case by case, individualized. Is the weight gain likely caused by another trigger, or is it likely the ARVs really are playing a role? How much is the person working on lifestyle and eating healthy, being active? And then what are my other options? And does it make sense to switch? And so for me, it's really an individualized decision. I have switched a couple people so far because of this, but not many. So how will we learn more? So we are a site for this ACTG trial called Do It, where we are enrolling people who've gained more than 10% body weight while taking an integrase inhibitor with TAF, and they are being randomized to either continue that regimen, switch to dolutegravir FTC TAF, I'm sorry, I misspoke, switch to doravirine FTC TAF, or switch to doravirine FTC TDF. So greater than 10% weight gain on integrase plus TAF, switch to doravirine with FTC TAF or FTC TDF, and they'll be followed, and they're getting scans for their body composition, their waist circumference is being measured, their weights are being tracked, a lot of markers of inflammation and cardiovascular risk are being tracked. So I think we'll learn a lot more from that. The overall enrollment is ongoing around the world, and I think we'll get data within the next year or two. There's also a trial called Define that is enrolling a similar group of individuals, but randomizing them to either continue their integrase and TAF or switch to boosted darunavir with FTC TAF. So it's integrase to darunavir. I'm not as thrilled about that. Looks like Stacy, you aren't as thrilled either, just because the PIs have their own set of problems. But that is another way that people are trying to learn what happens with a switch. I feel like I talked too much on that topic. I'm going to pause there. What do you think? Thoughts, reflections? What do you do? What have your conversations with patients been like?
Had a lot of guilt initially, because there were a couple patients who really were like, ever since you switched me to this regimen, like Biktarvy, I have been gaining weight. And we didn't really know at first, so, and not all of my patients were gaining weight. So initially I was like, here's lifestyle modifications, here's this, here's that. And then, ID week a couple years ago, all this came out, and it was like, ooh, and so I made some switches, and actually some of them have lost weight. I mean, what do I go to? I mean, if they really are wed to their one pill once a day, I've been doing Delstrigo. But I like Truvada, Doravirine as well. And almost all of them have really liked it. Now, how much weight they've lost, kind of varies. Some have lost a considerable amount, but actually they just don't gain more. That's the thing that I've noticed. Like, they may not lose a whole lot, but they don't really gain a lot more. I think the one thing that we're struggling with a lot, so I like that you're saying that it's not all patients, and it certainly isn't all patients, because I have patients who need to gain weight on Biktarvy who are not gaining weight, so it's certainly not everybody. I definitely have noticed it more in our female patients, and actually just based off of, we don't have a lot of African-American population here in Billings, but our Latinx patients are also gaining a lot of weight, which you had mentioned minorities. And we have in particular some male Latino patients who have a ton of fatty liver. I mean, they're gaining a lot of weight and they're having a lot of fatty liver. So that mouse study was actually super interesting to me in that regard, because I don't know exactly what's going on there, but we, in those patients, we have made several of them, we have made the switch to Doravirine and Truvada or Delstrigo, and we are not getting a lot of reversal of that fatty liver. I mean, some of them have lost weight, but their fatty liver has continued on in their transaminitis. So I don't really know. But that has been our experience. I don't know if Chris wants to jump in too. I mean, he is unfortunately burdened with the greater number of patients who seem to be having this issue. And I know it's something we talk about a lot in clinic.
Yeah, not much to add to what you said, Dr. Lee, except, yeah, I think we have switched quite a few people.
I think that's really interesting to hear and appreciate you sharing it. And it's, I think, an interesting anecdote that you switch people, and whether they lose or not, at least their weight stabilizes and it halts that trajectory upward. So I think that's really interesting. One thing I forgot to mention when showing you this mouse model is this piece here, this second bullet point where dolutegravir and bictegravir block the thermogenesis, the burning of calories. Parts of that are estrogen mediated. So one of the important parts of this, and why I thought it was important as a biologic mechanism study, is this may explain why individuals born female are more likely to experience this integrase related weight gain. I have had a similar experience to what you were describing, where some of my Black or Latinx patients have developed a lot of weight change after starting ART, and I don't think we understand that. And I don't think we understand if that is something with biology or if that is a social determinant of health and other things going on. I just don't think we understand it, and I think we need to understand better. I appreciate all of the sharing of perspectives, opening the floor again to everyone. Other thoughts, experience with this, or conversations you've had with patients? Well, hopefully we will learn more. I think we have ballpark half hour left. I'll show you one more treatment related case and then switch to an update from the PrEP guidelines. But again, please stop me if there's other things you feel like are more important to talk about. But let me just show you one additional case. This is again a case from my clinic, real case, 52-year-old gentleman, long-standing HIV. I've known him for a lot of years. Viral load suppressed on rilpivirine, FTC TAF, so it's ODEFC. His only ART prior to that was a efavirenz FTC TDF. That's a AAA. Unfortunately, when the pandemic hit, he had a lot of chaos in his life and a lot of struggle and had a period off his pills. During that period, his viral load rebounded to just over 1,000 and a genotype showed E138K. Sorry, my dog again, which is a rilpivirine resistance mutation and M184V. So I'm gonna pose this question to you. So NRTI resistance and a 184V. Let me pull it up. What would you offer him? What would you recommend? I've given you bictegravir FTC TAF, which is Biktarvy, Biktarvy plus doravirine, Biktarvy plus boosted darunavir, Simtuza, which is boosted darunavir FTC TAF, or please feel free to fire off something else if there's something else you would do. Give that a few seconds here. Okay, thanks very much, everyone. So we got 80% Biktarvy doravirine and 20% Biktarvy Prescobix boosted darunavir. So I don't think there's a right answer here. I do find it interesting. What I ended up giving him was Biktarvy, the first option. So I think it just shows there's no real right answer here, but low viral load, only an M184V. I think Biktarvy is plenty, but I don't think you're wrong with either of the other options. And another strategy, especially if the viral load were high, I think would be one of those other options, Biktarvy doravirine or Biktarvy Prescobix, and then once suppressed, pull off the doravirine or pull off the Prescobix. But I tend to think that bictegravir or dolutegravir plus 2 NRTIs is plenty with an M184V. And I think our thought process around this has evolved over the years. And this, I think, was an important update to the guidelines in June, where they really have said that instead of a new regimen should include at least 2, preferably 3 active drugs, 2 active drugs is plenty as long as one of them has a high barrier to resistance. So that's the bictegravir, dolutegravir, or boosted darunavir would count in that. A lot of that came from this study called Dawning. This made a bunch of headlines about 2 years ago when it was published. This was done in sub-Saharan Africa and looked at people with virologic failure on an NRTI-based regimen, like in the case. Many of them had NRTI resistance, including 184V, and a number of them even more NRTI resistance. And individuals were randomized to dolutegravir or boosted lopinavir, and then there was some variation as to the NRTIs that people got, and investigators could select the NRTI combo. But the important point here is that dolutegravir did very well. It did better than boosted lopinavir, and it really didn't matter if people had 184V, and it really didn't matter how many additional NRTIs they got, as long as people got dolutegravir and 1 active drug, they did well, even if their viral loads were detectable. About 20%, I think it was 21% in this trial, had a viral load above 100,000. And really, virologic failure with emergent resistance did not occur in anyone with an M184V alone. So I think there's growing data that if somebody has a high barrier to resistance med, that's dolutegravir, bictegravir, boosted darunavir, and 1 additional active drug, they're fine, especially if their viral load is undetectable or low. If their viral load's high, they're probably going to be fine, but I think there's low downside to adding doravirine or Prescobix until, or adding another active agent, I should say, until their viral load's suppressed, and then we can pull it back. And basically this ends up being, it ends up being one active drug with a very high barrier to resistance, and then 1 additional active drug. I would not do this with 2 drugs of relatively low barrier to resistance. I mean, that's really what makes the difference for me. And if you don't have a high barrier to resistance drug that's active, that's an option, then I'm back to the look. We really need to try to craft something with 3 active drugs. And that's basically what this is saying. So I think that's a place where not only has our perspective evolved over the years, but also the guidelines have changed to support that. So just wanted to show that. Oh, and the guidelines also added some more summary and detail about fostemsavir, which we're really using as a salvage drug. So just wanted to make sure everybody's aware of fostemsavir. It's an attachment inhibitor. It's a BID oral pill. So it does have a pretty unique mechanism of action. So people who have resistance to NRTIs, PIs, this is still an option. It is a BID pill. For some people that's challenging, but it's oral, This is the diagram from David Spock about the mechanism. So it blocks the GP120 attachment here, binds at a different place, has a similar but slightly different mechanism to ibalizumab. This is called a post-attachment inhibitor because of where it binds, but also blocking the same step of attachment. So this is another salvage drug. Ibalizumab is IV every 2 weeks, so really is a agent of last resort for the person with very few other options. So we have used it, but I can count the number of times on, well, definitely one hand, because it really is for the very small number of people who just have no other options. I threw in a latent TB case here. Let me do a quick latent TB case before we get to PrEP, because I think this is a good discussion. Be relatively quick though. So 40-year-old woman came to established care, recent HIV diagnosis, asymptomatic. It was a routine screen. You can see her labs there. Quantiferon is positive. She has no symptoms of TB. Her chest history is clear. She's from an endemic country and she's diagnosed with latent TB. She's never been treated before. So you plan to start ART and you're trying to think of the best option. We're starting ART, and then what are we going to give her for latent TB? So let me throw this poll out there and just ask. These are some of the options that I considered. Could do BIC FTC TAF daily as first line therapy with daily INH for 9 months. We could do dolutegravir FTC TDF daily with 3 months of INH rifapentine. We could bump the dolutegravir dose to BID and do FTC TDF with daily rifampin, or bump the dolutegravir dose to BID with FTC TDF with INH rifampin for 3 months. The key here being, if you're using rifapentine or rifampin, we're avoiding TAF and using TDF. Thanks, everyone. So, no clear right answer here. I think this is just good to consider. I don't think there's a right strategy here. I just wanted to remind everyone that these are the main options, and I wanted to highlight this key change to the guidelines, which is that dolutegravir can be once daily if you're using the 3HP, the 3 months of weekly INH rifapentine. That was a topic of question and controversy, and initially we were doing BID dolutegravir, but wanted to make the point the guidelines have now been changed. There's a little discrepancy in the OI guidelines and the ARV guidelines about this. The OI guidelines still push for INH as first line, but they haven't been updated. As recently, the adult treatment guidelines now link to the CDC recommendations, which favor short course rifamycin-based therapy. So just a reminder of the options: 3 months weekly INH rifapentine. You can do dolutegravir daily with that option, but with rifapentine, you shouldn't do TAF, at least for now. There's some data suggesting it might be okay, but for now, what's in the guidelines is use TDF. Rifampin for 4 months daily, definitely want to BID the dolutegravir. Right now, we are avoiding TAF with that, and then you can see there the 3 month daily option as well, and still very reasonable to do 9 months of INH, just lower completion rates. But you know, if you're trying to keep the ART to 1 pill a day, that's really the option. So I've made those points. Why don't we, and 1 HP, a 1 month option has been studied, but isn't in the guidelines yet. So 1 month of daily INH and oral INH and rifapentine worked really well. The trouble is half the people weren't on ART when they got it, and the other half were on efavirenz or nevirapine. So we just don't really know our ART options with this yet. So it hasn't hit guidelines, but if you really needed to get someone's LTBI treated within a month, you could consider this. You could consider switching them to ATRIPLA and doing this. Just know that it's out there, but it's really not in the guidelines yet. So let's talk about PrEP. We'll do 20 minutes or so of PrEP and call it a night, because I'm sure y'all have had long weeks and long days. So the CDC and you think it's largely what the final guidelines will look like. So I'll show you a few things. You all know what PrEP is. I'm not going to go through this. The options for PrEP and a couple of updates from the last year. So FTC TDF or Truvada, of course, was the first one approved. FTC TAF or Descovy approved for certain adults and adolescents in October 2019. I say certain because the approval did exclude individuals whose HIV risk is receptive vaginal sex. I think it really was a miss to not include individuals having vaginal sex in the clinical trials, and there is a trial ongoing to get data and try to correct that. But those are the current oral options. These were given grade A recommendations by the USPSTF, and then a letter from the federal government told state insurers that they had to cover all costs with no copays in July. So if you are getting pushback, not just on coverage of meds, but coverage on visits and labs, you can cite this letter and try to get coverage. So that was an important update from this summer that I wanted to highlight. Now, this is from the draft guidelines, so I don't know what will change, but I'm just going to highlight a couple things here about the baseline labs and monitoring. So it has not changed that we should screen for symptoms of acute or primary HIV, excuse me, at each visit, do a viral load if they are present, and delay PrEP if we are worried about primary HIV. Most individuals will not have those symptoms, and we do a screening HIV, usually a 4th generation antigen antibody at baseline, and then every 3 months. A Hep B panel so that we can offer Hep B vaccine if someone is not immune, and so we can know if someone has Hep B before we prescribe the FTC TDF or FTC TAF. A Hep C antibody and repeat annually for individuals who have risk either through drugs or through condomless sex of acquiring hepatitis C. And then monitoring renal function. This was a bit of an update on these new draft guidelines, so I want to highlight this. So we do check serum creatinine at baseline, and if someone has a creatinine clearance that is abnormal, we would probably make an argument for TAF over TDF. And so I think it is important to know at baseline. The update here is the draft guidelines said we should be rechecking the creatinine every 6 months if someone is over 50 or their creatinine clearance is below 90. Otherwise, we can follow up every 12 months. So that is what is in the new draft guidelines. So not very frequent kidney function monitoring while on PrEP. That said, if there are concerns, if there are risk factors, if you're seeing any sort of change, I don't think it's wrong to follow up more often. But they really do say we don't need to check that creatinine every 3 months with their HIV test. The bacterial STI screen, so 3-site testing and syphilis testing, really should be checked every 3 months if someone's risk is condomless sex. Pregnancy test still recommended. And then they added this, coming back to our discussion about weight, they added this, and I'm not buying it. I'm not going to be checking people taking PrEP. A lot of my PrEP patients are young and otherwise healthy. I am not going to be checking their lipids every 6 months. So this is in the draft guidelines, just so you know. This is one thing that I'm just not on board with. But as we were talking about, please know that individuals who take TDF may experience some degree of weight suppression. Individuals who take TAF may experience some degree of weight gain. Individuals who switch TDF to TAF may gain weight over 6 to 9 months. But I personally, sure, we'll track their weight in clinic, but we'll not check lipids every 6 months. The other things, coming back to renal function, they do say add a urinalysis if there are additional risk factors for renal disease, so that urinalysis is looking for signs of proximal tubulopathy from the TDF, especially less likely the TAF, so looking for new proteinuria, glucose in the urine, things of that nature. They do say to consider a visit at 1 month after starting PrEP to check in about adherence and side effects. And there are other things we should be including regularly, like discussions about adherence, risk reduction, condoms, clean needles, and then overall risk and whether it makes sense to continue PrEP, we should be discussing regularly as well. This again is from the draft guidelines. So if you have somebody who is an appropriate candidate for PrEP and have documented all of those important labs, then your options really are FTC TDF, or for men and transgender women at risk of sex, the daily oral FTC TAF, again, excluding individuals whose risk is receptive vaginal sex. The IAS USA guidelines add this comment that if creatinine clearance is 30 to 60, or there's osteopenia or osteoporosis or risk factors for those things, we should be leaning towards the TAF option instead of TDF. There is no clear good option for PrEP for individuals with creatinine clearance below 30. That has come up for us at least twice that I'm aware of in clinic. And in that setting, I think it becomes a clinical judgment and a discussion with the person that is off label. There are studies of HIV treatment giving TAF to people with creatinine clearance below 30 or even below 15, but numbers are small. It's not robust data. And then the most common side effects we counsel people about are really this non-specific startup syndrome, if you will, which usually gets better after the first week or two, but some people do require some assistance and antiemetics and things to get through that. I've certainly seen that. The decision to exclude receptive vaginal sex as an indication for FTC TAF as PrEP was controversial, just showing you this here. The bottom line, the panel voted 10-8 against approval for cisgender women or approval of receptive vaginal sex. So it was not clear cut. And it was a big discussion about whether the available data and the clinical trial called Discover that enrolled MSM and trans women, whether that wasn't enough to extrapolate for cis women. So just so you know, and hopefully that will be changed in the future. The other really interesting thing about cabotegravir, which I'll get to in a minute, is cabotegravir seems to have higher levels in cervical vaginal tissue than in the rectal tract, which is the opposite of these tenofovir-based oral drugs. So I think cabotegravir may end up being a very effective option for cisgender women. So these were the other things in the draft guidelines. It's okay to prescribe PrEP at a patient's first visit if they have no symptoms of primary HIV, you can get all their labs, and you know you can contact them when they get their labs back. We are not necessarily doing this in our clinic. We are seeing people for PrEP, and the reality is it usually takes us a couple days to get the meds approved, get everything through. So we're not, I may write their prescription at the first visit, but I think the reality is they're not starting their pills that day of the first visit, so I feel okay about it. But if you're in a setting where you want to start somebody that day, there is some data around it, there is some support around it, as long as you can get all their labs and contact them. And it is okay to prescribe PrEP by telemedicine. We are certainly doing that, though the biggest challenge I have found is getting people to do their labs, coming back to that setting. And if you're seeing them remotely and then saying, well, you still got to get in somewhere for labs, it can be challenging. Let's talk about 211 for a moment. So 211 is supported by the WHO guidelines and by the European guidelines. And now in this new CDC draft PrEP guidelines document, it does have a section on 211 dosing. They describe it as off-label because it's not in the FDA approval, but they do make some important recommendations around it. So if you're considering 211, which is the strategy of 2 pills before sex, 1 the day after and 1 the day after that, remember this has only been studied for cisgender MSM. And remember this has only been studied with FTC TDF or Truvada. It has not been studied for trans individuals. It has not been studied for cis women, and it has not been studied with Descovy. So if you are seeing a cisgender MSM who has risk for HIV and is a candidate for PrEP, and really isn't sure they want to take a pill every day, or isn't having condomless sex that frequently and their risk is really intermittent, I think 2-on-1 is okay to consider. It is described as off-label, but in this new CDC draft document, they give some guidance. They say if you're going to do this, prescribe no more than 30 pills without follow-up documentation of another HIV test. Again, only use TDF-FTC. They say that with 30 pills, it's basically 4 pills per condomless sex act. So person will have enough to cover about 7 episodes of sex. Counsel them about taking both the pre and post-sex dosing. Both are important. There has been in the trials of this more startup syndrome because people are going on and off of it than with daily dosing. So that is something to counsel people about. With daily dosing, people's bodies adjust and they get over those startup side effects. But with 2-on-1, they're continually going on and off of it. So some may struggle more with the GI upset and things like that. And do not prescribe 2-on-1 for people with Hep B, of course, because you'll be giving a Hep B drug on and off. So there is more support for this, I would say, in the updated CDC document. This is supported by the WHO and the European guidelines, and it was primarily, the studies were all led by European groups, so not surprising. A couple of clinical things that come up for me with PrEP in my clinic. You're getting that refill request and person doesn't show up to his visit or hasn't had follow-up labs. What do you do? And I think there's no right answer around this or no real guidance. There's something to think about. If a person is prescribed PrEP and then they come in with one significant HIV risk event, condom breakage with a positive partner, what do you do? And let's say they haven't been taking their PrEP regularly. When do you prescribe PEP? This is what the CDC says. Offer NPEP if they've been taking their PrEP sporadically or they've not taken PrEP within the past 7 days. I thought that specific guidance was rather helpful. This came up for me the other day in clinic with somebody who was prescribed Descovy for PrEP and then hadn't really been taking it, and then had a condomless sex with an anonymous partner and came in asking for PEP. And I said, okay, PEP's probably reasonable. Then what came up for me is, okay, but PEP, we're going to do Truvada raltegravir. So we're going to do 28 days of Truvada raltegravir and then go back to Descovy. It felt a little clunky and odd, but that's what we did. So things to think about, I guess. If you have a different strategy in that situation, I'd love to hear it. When do we, make sure somebody has labs before restarting? I don't know if there's a right answer. These are just things that come up for me in clinic. And then the drug-drug interactions. So feminizing hormones. So for the person getting gender affirming care and taking feminizing hormones, the trans woman or the non-binary individual who's taking estradiol, plus or minus other feminizing treatments, the estradiol probably reduces tenofovir levels a bit. It doesn't seem to be enough to make daily PrEP ineffective, but it's one of the reasons we don't recommend 2-on-1 for trans individuals or for people taking feminizing hormone therapy. We really emphasize adherence to daily dosing. There are interactions between tenofovir and some Hep C drugs, and we talked about rifamycin and avoiding TAF. I haven't had that come up with PrEP, but let's talk about cabotegravir and long-acting PrEP, and then we'll have a couple minutes for questions and end on that. So this is coming soon. We should hear about cabotegravir by the end of January. So last poll question here. Last poll question here. Thinking about your PrEP patients, how many of them do you think are going to want to come in every 2 months? So cabotegravir for PrEP is every 2 months. How many of them do you think will want to switch from their daily oral PrEP to coming to clinic for a shot in the butt every 2 months? Okay, so not everyone. I kind of feel the same. Not everyone, but some will. So there are lots of new things in development for PrEP, there are other oral therapies that are not tenofovir based. There are vaginal gels, there's a vaginal film, there's a vaginal ring that's also being reviewed by the FDA, and then the injectables, some of which I've mentioned, and the implant, which I mentioned. This is cabotegravir. This is what it looks like. Again, for PrEP, it will be an IM injection every 2 months. And this is the 083 trial, which made a lot of news because this is what proved that IM cabotegravir was not only effective for PrEP, it actually was more effective than oral Truvada, probably driven by missed doses of the Truvada and adherence, but very effective for MSM and trans women. And this 084 study in cisgender women also found IM cabotegravir to be very effective, even more effective than for MSM or trans women, and much more effective than oral FTC TDF, again, largely driven by missed doses of oral FTC TDF. But this is really profound reductions in risk of HIV with cabotegravir. One thing that's come out of the cabotegravir studies, though, is in the trials, the people who did acquire HIV had very confusing lab tests for HIV, which delayed their diagnosis. So they had false negative results, they had indeterminate results. It took a fair amount of work to confirm and diagnose HIV for those who were receiving the cabotegravir. So this has been a source of a lot of discussion. And I think we will get recommendations about how to test and monitor for HIV for people receiving cabotegravir, and it may be different than for people receiving oral PrEP. Now, this is I want to highlight, this is from the draft CDC guidelines, so this may not be the final recommendation, but in the draft, they say we need a viral load, not just a 4th generation screen before starting IM cab for PrEP. Now with cabotegravir, we don't have to worry about renal function or Hep B, though I think getting people immunized for Hep B is always worthwhile, but there are benefits to cabotegravir. This is the dose for PrEP. Doses to be done in clinic, not home. As I mentioned, the oral lead-in is likely to be made optional because cabotegravir is so well tolerated. And then they say repeat viral load at 4 weeks, and then every 8 weeks, basically with every dose, repeat the viral load. We will see if this is what comes out in their final guidance and what the FDA says when they approve it, but this is what was in the draft CDC documents. For those of you who participate in our Project ECHO, we are going to have Rafi Landovitz, who led 083 back in January, to talk more about this. So if you participate in our ECHO sessions on Thursdays, stay tuned for that in January, because we'll be able to pick his brain about this, because this is a really important topic that Rafi and others have been giving a lot of thought to. Injection site reactions were common, but they were mild, transient. Warm compresses and heating pads helped, and they really didn't. Very few people stopped their cabotegravir because of the injection site reactions. The FDA is reviewing these dapivirine vaginal rings and may approve them. The WHO has approved and endorsed them. So these are vaginal rings that are changed every month and that release a NNRTI called dapivirine, an NNRTI that's not available as an oral pill. The risk reduction in HIV was more modest than with oral PrEP or than with cabotegravir, but it was still statistically significant and was still substantial. So this may be an option for certain individuals. I don't think it's likely to get a lot of use in this country. These studies were all done in sub-Saharan Africa. Adherence was not perfect. Sadly, a lot of women were afraid of their partner feeling the ring, and there was a lot of fear of intimate partner violence and repercussions, and adherence was not perfect. So this option may be approved by the FDA, although I don't anticipate it's going to get a ton of use here. The implants, coming back to the implants, are exciting and cool, and the company making the islatravir implant is the same company that makes Nexplanon, so it looks like the Nexplanon implant. And basically will be that size and will look very similar. And then there are some other things in development as well. So the future may be options where we can help people individualize PrEP, similar to how we do with contraception. These are some additional resources for PrEP, but I think with that, we're pretty close to time. That's my favorite safe sex graphic, which I've probably shown you before. And I'm happy to stick around for a few. And maybe I'll just see what questions do you have about PrEP and either what's coming for you in clinic or what's coming. And then maybe I'll give a moment for that and then we'll wrap up. PrEP questions, controversies in your clinic, questions in your clinic, or questions about what's coming. I hope that review of what's out there and what's in the new CDC draft document and then the new meds was useful. And as questions come up, feel free to reach out to me. And for those of you involved in our Project Echo network, please, you know how to pose questions to us on that. And if you're not involved and want to get involved, please feel free to reach out to me and let me know. Molly.
Thank you, Brian, and thank you everyone for participating this evening. This will be recorded and I can send it out. Please make sure that you registered. The link was on your invite to register, just so that we have your information, because it helps us with tracking for our grant. And we'll be sending out an evaluation next week, early next week, if you wouldn't mind filling that out. So. And if you have any training requests for your clinics, please feel free to get a hold of me. I put my email in the chat and then the link to the registration in the chat as well. So thank you again, everyone, and I hope you have a great weekend.
Thanks very much, everyone, for your time.
Great as usual.
Thank you very much.
Thanks, Brian.
Thanks, Vinny. Thanks, everyone. Yeah, hope you have a great weekend. Hope to see you all sometime soon.